thank you for the invitation to come and speak, and thank you for that introduction. So my interest really, as Barbara mentioned, is the use of specific diets to help manage gut conditions, and in particular functional gastrointestinal disorders. Today I was going to try and cover the use of fibre in these sorts of conditions as well as the low FODMAP diet, but I realised that I didn't quite have enough time to cover both, so I am actually just going to mainly focus on the low FODMAP diet in this session, and hopefully I've tailored it for this audience appropriately. So we've got time at the end, I'm sure, for questions and things, so please feel free to ask questions at the end. So first of all, I'm going to present to you a little bit about functional gastrointestinal disorders themselves, what they are, their pathophysiology and the burden for patients that have these conditions. And then I'll really go straight into the low FODMAP diet, discuss what the diet entails, discuss a little bit about its efficacy in this patient population, how it works, and then some of the consequences of the diet. So, for example, the impact on nutrient intake, the impact on the microbiota, and then a little bit more about what the diet means for patients, for clinicians, and also for the food industry. So functional gastrointestinal disorders, what are they? They're a group of a number of different conditions where patients experience gastrointestinal symptoms, they're investigated extensively, and there's no organic cause or structural cause for their symptoms. So they're then diagnosed with one of these functional gastrointestinal disorders, and the main one is irritable bowel syndrome that I'm sure we've all heard of. This is a disorder, there's a Rome 4 diagnostic criteria for this condition, and it's really characterised by the presence of abdominal pain, but also a change in bowel habit. So 2 of those 3 different criteria need to be met for the diagnosis of IBS to occur. And the symptoms do need to have been present for at least 6 months. They're not transient, they're symptoms that have been around for quite a long time. So it's a really common condition. About 10 to 15% of the population worldwide have irritable bowel syndrome, and it does present quite a burden to these patients. And, you know, we hear about IBS all the time, and I think a lot of people think this is quite a benign condition that doesn't really mean very much. You have a bit of gas, you have a bit of pain, it doesn't actually impact people, but actually the quality of life of patients can be really, really affected by this condition. And this is a review article that was published a few years ago now, suggesting that on average, the reduction in quality of life in patients with IBS would actually be that bad that on average they'd sacrifice 10 to 15 years of their life for an immediate cure. So we're talking about a pretty difficult condition for a lot of patients. So something for us to really be aware of when we're thinking about IBS and ways to manage the condition. So the pathophysiology of irritable bowel syndrome, but also some of the other functional gastrointestinal disorders, is pretty complex. You can see there's lots of different factors that are involved and that interact with each other. And I'm not going to spend too much time on this, but we know that, let's see if this pointer works. We know that anxiety and depression is very common in these patients, and that can contribute to symptoms. We know that there's this disturbed brain-gut axis that is very different to people that don't have this condition. There's some patients that have an activated immune system, which is associated with impaired gut barrier function. And certainly, and of interest to me, we know that some people have dysbiosis or an altered microbiota compared with healthy individuals. And all of these work together to really impact on the gut and the sensitivity of the gut to the luminal contents, whether it's food or gas, and even impact of stress on the gut. This is the bit that's of interest to me, is this altered gut microbiota. A lot of studies suggest that alpha diversity is lower in patients with irritable bowel syndrome, so the number of species present in the stool is lower. And there's also fairly consistent findings that bifidobacteria abundance is lower in a proportion of patients with this condition. So moving on to the low FODMAP diet, this is a group of carbohydrates. Some of you may have heard of this particular approach already, but it's a diet that really targets a small group of carbohydrates that we understand are rapidly fermented in the large intestine. So they pass through the small intestine undigested and therefore are available in the colon for fermentation by the bacteria there. And this is a diet that was developed probably about 10 to 15 years ago by a group at Monash University in Melbourne. And there's an increasing body of evidence now that this diet is really quite effective in managing gastrointestinal symptoms, particularly in irritable bowel syndrome. And you can see here, I mean, sorry, the font is very small, but you can see the low FODMAP diet is now part of these clinical guidelines for dietitians who see patients with irritable bowel syndrome. And this was a publication put together by the British Dietetic Association Specialist Interest Group for Gastroenterology. So it's certainly a diet that's becoming much more well known around the world and is increasingly being utilised by clinicians, dietitians in clinical practice. So looking at each of the different FODMAP carbohydrates in a bit more detail, first of all, the oligosaccharides. So these are short chains of carbohydrates. Fructans, first of all. This is a fructose polymer with a glucose terminal end. You can see there's a number of different types of fructans that are available in the food supply with varying degrees of polymerization. But overall, the important thing to understand here is that we can't digest these carbohydrates. So we don't have the enzyme to digest the carbohydrate and therefore absorb it into the bloodstream. So most of it ends up in the large intestine and becomes available there for the bacteria to ferment. These fructans are found in a number of different foods throughout the diet, in particular things like wheat products, rye products, and onion and garlic. And also they can be added as an added ingredient in some processed foods. So for example, inulin is often added to dairy products. It's a bit of a fat replacer, so it gives a nice texture to products, and it's also often in yogurts. So not only naturally occurring, but is added as an added ingredient to some processed foods. Something of interest to note here is that fructans are also defined as prebiotics. So it's a substrate that is selectively utilised by host microorganisms and can confer a health benefit as a result. So important to note, this is an important carbohydrate for the purposes of health, but in particular for IBS and people with gut symptoms, it can be an issue. And so this is one of the carbohydrates that we do target when we put someone on the low FODMAP diet. But important just to remember this prebiotic effect when we talk later about the impact on the microbiota. The other oligosaccharide we're interested in here is the galacto-oligosaccharides, and these are galactose monomers with a terminal glucose unit, so up to 10 monosaccharides joined together. Raffinose and stachyose are the main galacto-oligosaccharides in the diet, and again, they're generally almost all indigestible due to the lack of the enzyme to be able to digest this carbohydrate. And there's some nice publications presenting the composition data for foods for fructans and galacto-oligosaccharides that have come out from Monash University a few years ago now. And galacto-oligosaccharides are generally found in pulses, so legumes, lentils, baked beans, chickpeas, etc. Again, sorry, this hasn't come through very well, but galacto-oligosaccharides are prebiotic, so keep that in the back of your mind when we talk about the impact of the low FODMAP diet on the microbiota. The disaccharide that is important when we're thinking about the low FODMAP diet is lactose. And of course, we're all familiar with this term lactose. It's the main sugar in dairy products. It's a disaccharide of glucose and galactose. We can hydrolyse this disaccharide by lactase, which is the enzyme in the small intestine that can break this into two monosaccharides, and then those monosaccharides are absorbed quite nicely into the bloodstream. But certainly hypolactasia is prevalent worldwide, particularly in Asian and African populations, and as we age, our lactase activity does go down as well. So as I said, lactose is present in dairy products, but it's also often used as a filler in drugs, and it's also used as an additive in products as well, for example, as a browning agent in breads. The monosaccharide we're interested in here is fructose. So this is a 6-carbon monosaccharide. We can absorb some fructose from our small intestine, so it's not completely available in the large intestine for fermentation, but it does depend on how well we're able to absorb it, either via GLUT5 or GLUT2. And this is, the absorption is really variable, so it does depend on how much fructose is available, whether glucose is available, and how active our GLUT5 transporter actually is. So when we're advising patients on the low FODMAP diet, we do allow fruits that have sufficient glucose in the fruit to match the fructose content. So we certainly don't exclude all fruits on the low FODMAP diet. But fruits that are excess in fructose over glucose, like apples, mango, and also honey, are particularly avoided during the restriction period, because some of that fructose will be malabsorbed and enter the colon. Polyols, so this is the final group of carbohydrates that I'm going to present to you. These are sugar alcohols, and there's a whole different range of polyols found naturally occurring in the diet, but also added to packaged foods. So sorbitol and mannitol are found in quite a lot of fruits and vegetables, including pears, mushrooms. But then we've also got things like xylitol, lactitol, isomalt, and particularly sorbitol and mannitol also found in sugar-free gums and sugar-free mints. So polyols are absorbed, but it's a slow process. They're absorbed by passive diffusion. And you can see here that not a huge percentage of people that are healthy or with irritable bowel syndrome can complete a 10-gram load of these polyols. So certainly quite a lot of this in the diet will pass through to the colon and be available for fermentation by the bacteria there. So in summary, we have GOS and fructans that are pretty much incompletely digested and pass all the way through to the colon, 90% of it or more. Then we've got fructose, which can be absorbed via GLUT2 and GLUT5, but not all of it, particularly if we eat it in large doses and there's no glucose present. Then we have lactase that can be absorbed if lactase activity is sufficient, but otherwise that also passes through to the colon. And then we've got polyols that are variably absorbed. Absorption is slow, and a lot of it will pass through, particularly if there's a lot consumed in one sitting. So what determines whether a food is considered high FODMAP or low FODMAP or medium FODMAP? This group at Monash University in Melbourne that I mentioned earlier have published this paper recently and have actually set out the cut-offs for what determines a food to be high FODMAP or low FODMAP. And they're really based on a lot of clinical experience and looking at the FODMAP content in a single meal that would commonly trigger symptoms in patients with irritable bowel syndrome. And so you can see here from this table, using lactose as an example, a product that has less than 1 gram of lactose per serve would be considered low lactose. But for polyols, less than 0.4 grams of polyols in a food is going to then mean that it's a low FODMAP food. So just to show that there is work that has been done to define the FODMAP content of foods, and this is used around the world to then provide patients with suitable and unsuitable food lists for them to consume while they're following the diet. And these cut-off values have been tested. You can see here that this research group have devised low FODMAP and high FODMAP foods and meals for patients and used them in their clinical trials and shown that they have been effective in reducing symptoms when patients are given the low FODMAP diet for a week, say, and their symptoms are worsened when they're given a high FODMAP diet based on that kind of a menu plan. So this has been tested through clinical trials. So I have mentioned that this is a diet that we use in clinical practice. It's part of our clinical guidelines, and there has been a lot of work done to show that the diet is clinically effective in reducing symptoms in people with irritable bowel syndrome. There's at least 11 randomised control trials that have been performed. And I think the important thing here is that in irritable bowel syndrome, the placebo effect is really strong. So in drug trials, 40% of people will report that they're feeling better after they've had placebo. So just the fact that they're meeting with the research team, they're involved in a trial, that is sufficient to improve people's symptoms or their report of symptoms. So when we're testing the efficacy of an intervention in this particular condition, it's really important that we compare it to a placebo intervention. And the same goes when we're testing out diets. So there actually has been some placebo-controlled trials investigating the effect of the low FODMAP diet. And the first one was one performed by Emma Halmos from Monash University. This was a feeding study, so all patients received all their food and fluid for a period of 3 weeks, and then there was a washout period, and then they received another 3 weeks worth of food and fluid. So it's a huge undertaking, as you can imagine. And patients received a typical Australian diet or a low FODMAP diet. They were blinded to the interventions, they didn't know which one they were getting first, and then they measured their symptoms on this visual analogue scale. And you can see over a 3-week period on the low FODMAP diet, patients got better over time. This is a measure of their overall symptoms. And then on the typical Australian diet, which was the placebo diet, their symptoms pretty much stayed the same. So this was the first evidence, placebo-controlled evidence, that the low FODMAP diet is effective in improving gut symptoms. The problem with this study is that in our clinical practice, we don't give patients all their food and fluid for 3 weeks at a time. We advise them, then they have to go away, do the diet themselves, comply with it, do their best on their own in the real world. So this could actually be quite an overestimation of how effective this diet actually is in real life. So as part of my PhD, I actually performed a placebo-controlled dietary advice trial of the low FODMAP diet. And the only way to really do that is to devise a placebo diet and teach patients how to do this placebo diet, which, as you can imagine, is quite difficult. So we designed the diet. The diet was no different in FODMAP content compared to their normal diet, and it didn't alter fibre intake, but it was sufficient in nutrients. And they thought they were on a special diet for their gut symptoms. And at the end of the 4-week period, you can see the group that got the sham dietary advice, about 40% of them reported relief of their symptoms. And in the low FODMAP group, about 60-odd% of patients reported relief of their symptoms. So there was a difference there. It wasn't quite significant, but when we looked at individual symptom response using a number of other different validated tools, we saw that there was actually a really strong effect of the low FODMAP diet compared with placebo. So from these placebo-controlled trials, we're pretty confident that this diet is effective, and overall, probably between 50 to 80% of people get a lot better when they're on the low FODMAP diet, according to all these randomised controlled trials I've mentioned to you. So how does the diet work? I have spoken about this fermentation aspect, and I'll come to that in a minute. But another way that FODMAPs could worsen symptoms, and therefore removing them could improve symptoms, is that they actually increase small intestinal water. So this is some work that's been done by Robin Spiller and his group in Nottingham in the UK. And they've done these really nice imaging studies to show that when you give people, and this is people with irritable bowel syndrome, if you give them big doses of FODMAPs, so in this case fructose, and they also gave inulin, and compare it to a control, which in this case is glucose. This is really well absorbed, high up in the small intestine. You can see that there's a huge effect of small intestinal water in the fructose group compared with controls. So you give a lot of fructose, the water content in the small intestine goes up dramatically, but not so much for inulin and glucose. And if you think about the visceral hypersensitivity that I was talking about earlier in the presentation, having all of this extra fluid in the lumen of the gut is likely to induce symptoms in susceptible people. And in this diagram here, you can see the white being the fluid or the water in the lumen. You can see how little there is after glucose, because glucose we know is well absorbed high up in the small intestine, whereas the fructose is still present in the small intestine, has this osmotic pool, and there's loads of fluid in the small, all the way through the small intestine in that same patient at the same time point. So currently at this stage, this is one of the ways that we think FODMAPs induces symptoms, this effect on small intestinal water content in the lumen of the gut. And then the other mechanism relates to gas production. So this is data from the same group in patients and in healthy volunteers, so people without irritable bowel syndrome. If you give inulin at 40 grams compared with glucose, and the other one's fructose, you can see inulin induces a huge increase in colonic volume compared to the other two sugars. And exactly the same thing happens in healthy individuals. So the physiological outcome is the same. Inulin leads to this colonic fermentation, ends up in the colon, bacteria like this carbohydrate, they ferment it, gas is produced, but the exact same thing happens in volunteers. So it's not the fact that their gut's different, the bacteria are different, the bacteria are producing more gas in the patients versus the controls. It's just that they can't handle this gas as well as the healthy individuals. So you can see when symptom intensity was measured, the volunteers actually recorded their symptoms as very low right at the beginning, and it hardly changed throughout. Whereas in the patients, they had symptoms at baseline in the fasted state, which is normal, we would expect that, but actually it increased significantly after inulin versus glucose and fructose. So it's the fact that the patients have this visceral hypersensitivity and are really sensitive to those changes in gas and will experience symptoms as a result of that is the issue here. So in summary, we know that many of the FODMAPs in our diet pass through into the colon. We know that fluid is drawn into the lumen of the bowel as a result of things like fructose and mannitol. And we also know that these carbohydrates are fermented by the bacteria and byproducts are gas as well as short-chain fatty acids. And in people with irritable bowel syndrome and visceral hypersensitivity, that distension induced by the gas and the fluid will lead to symptoms. So the whole theory of the low FODMAP diet is we remove these carbohydrates, luminal distension is reduced and therefore symptoms improve. So I just wanted to sort of pause here and say that this diet is being really used widely around the world. Dietitians love it because in the past we've really struggled to be able to manage people's symptoms prior to the use of this diet. But there are a lot of groups around the world that's quite critical of the diet, and I can understand that. There's still lots of questions about the diet itself. So I think some of the positives are that we know, according to the research that's been done, it works. There's these placebo-controlled trials that demonstrates that the diet is effective compared with placebo. We know generally the mechanisms, so we know the impact on small intestinal water and colonic fermentation, and that they're likely the main mechanisms by which this diet has its effect. But there's lots of questions still. And the main questions that have been asked are, okay, a lot of the studies have measured symptoms at 4 weeks, 6 weeks, 8 weeks, but what about 12 months? What about 18 months down the track? And there is some data on this over the last sort of year or two that's come out, and I'm not going to present to you on that today. But I think there's still some questions around this. Some people say, well, this is a restrictive diet. You're removing lots of fruit and vegetables, you're removing whole grains. How do we know the diet's sufficient? How do we know patients are meeting all their nutrient requirements? And then the other big question is, we're removing some prebiotic carbohydrates from the diet. What happens to the microbiota? Are we causing some impact on the colon in the long term? So still lots of questions that need to be answered, and I think we have answers to some of them, but there's still lots of work to be done. So I just want to touch a little bit on the nutritional consequences of the low FODMAP diet. You can see here, this is a comparison of patients who were randomised to continue their normal diet, so that's the control group, patients randomised to receive low FODMAP dietary advice, and this is their nutrient intake at 4 weeks. And you can see energy intake, protein, fat intake was not different between the two groups. Carbohydrate was different, which we would expect, although 200 grams a day is still quite a lot, so we weren't too concerned about that. Starch and sugar intake also changes, which again, we're not too concerned about that. Fibre intake, using non-starch polysaccharides here, was no different. So people can remove these fermentable carbohydrates but still maintain their overall fibre intake. But one thing that we did note was that calcium intake was lower in the low FODMAP group. So they were advised to go low lactose, choose low lactose, high calcium products, but they still didn't quite do as well as the habitual diet group. This was a small study, so what we've done is combine the results from 2 trials, and this is just presenting data in a slightly different way. This is the proportion of patients that are meeting their nutrient recommendations. So you can see, for example, for protein, many people were able to meet their recommendations at baseline and then at 4 weeks after, whilst following the low FODMAP diet. Overall, you can see there's not really many differences between baseline and low FODMAP. I'd say overall there's quite a few people that at any time point aren't really meeting their requirements, but I'd say it's probably going to be a fairly similar picture in the healthy population. But actually, again, we see that calcium intake was perhaps a problem. Fewer people could meet their requirements on the low FODMAP diet, and we also see the same thing for thiamine. And this might be because we're asking people to reduce their wheat intake, and wheat products often come fortified with B vitamins. So if you're thinking about breakfast cereals and breads, this could be the reason why some people weren't able to meet their requirements. But overall, broadly speaking, patients are doing pretty well. I would suggest that, for many nutrients, the low FODMAP diet is still able to provide sufficient, or at least not less than baseline. What about the effect on the microbiota? So as I mentioned earlier, some of the FODMAP carbohydrates are considered prebiotic in nature. And what we're doing when we're advising someone to go on a low FODMAP diet is we're asking them to reduce their fructans and their GOS intake, both of which are prebiotic. So the concern would be that maybe we're impacting on the abundance of some of the beneficial bacteria in the gut. Now, there's been quite a lot of interest in this over the past few years. 6 or 7 studies have now been done where patients are put on the low FODMAP diet and they measure the microbiota composition in the stool before and after, or compared with a control group. You can see the duration of these studies is pretty much 3 to 4 weeks. The FODMAP intake is pretty variable, which I think is something to really bear in mind when we're looking at these findings. You can see that these 2 studies have really brought FODMAP levels to a very low level, and it's likely because they're the 2 feeding studies, so they're able to really control patients' dietary intake really quite strictly. And you can see also the technique that was used to measure the microbiota really varies from one study to the next. So the level of depth that we're able to look at the microbiome is really dependent or varies from one study to the next. And I've just collated some of the basic findings from some of these studies. You can see that overall, many of them do measure bifidobacteria and do show that there's a reduced abundance of bifidobacteria after the low FODMAP diet compared with habitual diet or compared with the control diet. The other thing to really note here is that 3 of them were able to measure diversity due to the technique that they were using, but there was no impact on diversity. Bearing in mind that diversity, the greater the diversity of species in the stool has generally been linked with health, and a lower diversity has been linked with chronic disease and so forth. And also bearing in mind that irritable bowel syndrome, a proportion of patients do have an altered microbiota, and consistent finding is that diversity is lower in these patients. So I think this is potentially reassuring, if anything. The other thing to bear in mind here is that, there's been a lot of focus on the composition of the microbiota and what goes down, what goes up, what doesn't change, but perhaps something that's more important is their activity. So what is the activity of the bacteria that are there? And in particular, something that I would be interested in is the impact on short-chain fatty acid production. So we're changing the carbohydrates that enter the colon, we're reducing certain fermentable carbohydrates that get here, does that mean then that we have less of this being produced? And some studies have measured short-chain fatty acid concentration in the stool, not particularly many, given there's been 10 or 11 randomised controlled trials, but the findings are pretty variable. And I think one problem here is that when we measure short-chain fatty acid concentration in the stool, all we're measuring is what comes out at the end. A lot of this actually is absorbed back into the bloodstream. So it's really difficult to measure production of this. Another study came up with these findings, which I think are quite interesting. They randomised patients to a low FODMAP diet or a high FODMAP diet, the high FODMAP diet being presented by these red dots, and people who were randomised to the low FODMAP diet presented with these green dots. And you could see the two groups were able to be separated pretty clearly based on the metabolic byproducts from the bacteria in their urine based on metabolomic analysis. There was 2 or 3 different metabolites that particularly separated the two groups, and one of these was histamine, which is known to be a marker of immune activation. So some really interesting findings out there, particularly this finding, I think, given that we know that a proportion of patients do have low-grade immune activation. But I think there's still lots more work to be done in this area. I'd be quite interested to know about metabolic byproducts of bacteria like protein fermentation byproducts and polyphenol breakdown pre and post low FODMAP diet. So I think there's a lot more to be done and a lot more that's going to be coming out over the coming years. There's also been some attempts to try and attenuate the impact of the low FODMAP diet on the microbiota. And as part of my PhD, I actually wanted to know whether addition of a probiotic to a low FODMAP diet, whether that would be effective in preventing this impact on the bifidobacteria. So what we did was randomise patients, as I mentioned earlier, to low FODMAP diet or sham diet, but in fact they also got a placebo supplement or a probiotic supplement. So we really wanted to see whether addition of a probiotic could prevent the effects of the low FODMAP diet on the gut microbiota. And these are the findings. This is the bifidobacteria abundance, the change at the 4-week time point compared to baseline. So anything below this line represents a reduction in abundance, anything above this line represents an increase in abundance. So you can see the sham diet, which we were hoping wouldn't do anything, didn't when they got the placebo supplement. If they got the probiotic supplement, their bifidobacteria went up. And then in the low FODMAP group, we saw a reduction in bifidobacteria abundance, which is consistent with findings from other studies. And then, of course, if we added in the probiotic, you could see that it did help to maintain abundance relative to baseline. So in this study, it appeared that this probiotic was effective in preventing those changes that we'd seen earlier. And this makes sense. We chose our probiotic carefully, lots of strains of bifidobacteria, really high-dose probiotic, and it seemed to do the trick. In clinical practice, however, we don't recommend this. One reason being that this is actually really, really expensive, and not everyone's going to be willing to spend that much for 4 weeks plus while they're doing the diet. The other reason that we don't routinely use this probiotic in clinical practice in conjunction with the low FODMAP diet is in clinical practice we actually have this reintroduction process. So what happens is we have patients do the low FODMAP diet for 4 to 8 weeks. You can see this is the FODMAP intake here represented by the blue line at baseline, and then while they do the diet, the FODMAP intake goes really low to see whether we can help improve their symptoms. As I said, 50 to 80% of people get a lot better, gut symptoms go down. Then we have this process for a decent length of time, 6 to 10 weeks, where we actually reintroduce these FODMAP carbohydrates in one by one to test patients' tolerance. So polyols are challenged, fructose is challenged, lactose, etc. are challenged individually over a 2 or 3 day process. And you can see that symptoms will go up if they're sensitive to one or more of these FODMAP carbohydrates. Then in the long term, what we want is symptoms to be better, so under this threshold. So symptoms are really well managed, but their FODMAP intake is actually quite a lot higher than it was at baseline. So we're really trying to promote an increase in some of these FODMAP carbohydrates, including those prebiotic carbohydrates that I mentioned, FOS and GOS. So we know that here we have a reduction in bifidobacteria abundance, according to all those studies I presented earlier, but actually we really don't have very much detail at all about what happens here. So we've increased prebiotic carbohydrate intake, but we don't know whether this actually shifts the microbiota abundance and composition back to baseline levels. So we really need to know that before we start recommending this expensive probiotic in practice, I think. The other thing we really need to know is the impact of the low FODMAP diet on the microbiota detrimental in the first place. Yes, we see a reduction in bifidobacteria, but does that have any implications for colonic health? We actually don't know the answer to that. As I mentioned earlier, diversity is unchanged in response to a low FODMAP diet, so that's possibly reassuring. The other issue is that in all of these studies, what we're sampling is the stool. So we're measuring the bacteria in the lumen of the bowel, but actually it might be the mucosal layer that's more important when we're thinking about disease pathophysiology. And all the studies that have been done, fair enough, stool is much easier to collect and sample than getting a mucosal biopsy from all of our patients. And then, as I mentioned earlier, we don't know very much about what happens to the functioning of the bacteria compared with, we know much more about the composition, but we don't know very much about whether the low FODMAP diet's impacting on function. And I think we need to know and understand that a little bit better before we can answer that question. So, taking into account everything I've presented to you today, a bit of a whirlwind tour of the low FODMAP diet, what are the implications for patients? Well, all the data that I've presented to you so far has been based on research that's been dietitian-led. So all the patients have been advised to follow the diet from a dietitian who's experienced in this approach. So it's effective, but at the moment it's effective only when it's dietitian-led. It's a complex diet, and the dietitian will be able to provide really useful resources to the patient to be able to do it really well and to get the maximum benefit. And there's loads of resources and apps that will really benefit patients to be able to do the diet properly. And I think dietitians need to start educating the patients about understanding the balance. I think there's this sort of thought that FODMAPs are bad, FODMAPs are going to cause me all these symptoms, but actually we need to be educating our patients about the positive impact of some of these carbohydrates, particularly the prebiotic carbohydrates that we're targeting. And I think the implications for dietitians here are that we need to really focus on calcium intake, making sure that patients, particularly in the longer term, are achieving their calcium requirements. And also that the reintroduction process is started really early so that patients can start to really test out their tolerance and ensure that they're getting enough of these prebiotic carbohydrates right from the start. Something else that's really important to note, I think, is that we're removing this group of fermentable carbohydrates, but actually we can still include a whole lot of fibres in the diet in the background while people are following the low FODMAP diet. Things like resistant starch, beta-glucans and cellulose are all present in these low FODMAP foods. So it's really important that we're able to provide these substrates for the microorganisms in our gut whilst reducing the FODMAPs in the diet and managing symptoms. The food industry is also engaged in this. There's now 2 different programs whereby the food companies can certify their products as low FODMAP. Monash University has one program, and then FODMAP Friendly has another, and you can look on their website and see there's multiple food companies that are really interested in this and brand their products accordingly. And I think the 2 main sort of food groups that patients struggle the most with are breads and cereals. So they need to avoid lots of wheat, lots of rye because of the fructan content. But in the past, we've really only been able to focus on these patients using gluten-free products, and often patients don't like them because they're quite crumbly and fall apart and don't taste so good. But Baker's Delight, this is a fairly new product that's come out. They've produced this LOFO loaf. I haven't tasted it myself, but I've got lots of good reports from people. It is a wheat bread, but it's been processed in such a way that the fructan content is pretty low and is able to be certified as low FODMAP. It is a source of fibre, but it's not particularly high in fibre. And then this is another product that's fairly new, a low FODMAP flour. It is a wheat flour, but it's been milled in such a way to remove a lot of the fructan. So again, it's able to be certified as being low FODMAP. So just some of the new products that are out there that patients are really happy about, I have to say. The other group of foods that patients often struggle with are ways to add flavouring to food. So we ask them to limit their onion and garlic intake, and that actually rules out a whole lot of products in the supermarket because onion and garlic is in a lot of processed products, whether we're talking about sauces or soups or dips and so forth. So there's lots of products now that are out there that are certified as being low FODMAP and a really useful addition to patients, particularly if they don't want to start a meal from scratch. So in summary, the low FODMAP diet is effective. It leads to improvement in symptoms in a large proportion of patients. I would say generally nutrient intake is broadly maintained, although we do need to be careful about calcium intake in particular. There's certainly microbiome shifts, but I think at this stage it's not clear if that's detrimental in the long term. And there's certainly opportunities for the food industry here, particularly for low FODMAP products, I think, that do optimise overall fibre intake. So thank you for listening. Thank you to Mark and Gerald, who I've been working with over the last year and a half or so, and then to everybody in London who supported me and collaborated with me throughout my PhD. So thank you for listening.